Hello and welcome. I'm Susan Dentzer, Senior Policy Fellow at the Duke Margolis Center for Health Policy. Very pleased to be moderating this panel for the Better Medicare Alliance today. Our topic today is high quality healthcare in the 21st century. Now, achieving high quality healthcare in the 21st century and possibly beyond that is, of course, the stated aspiration of probably everybody listening to this session today, including, of course, Medicare Advantage plans. But achieving high quality healthcare is way too complex and objective for anybody in this business to go it alone. Everybody in this quest needs partners, including MA plans. So our panels today come from 3 different organizations that partner with MA plans to address particular beneficiary needs. And let me introduce them to you now. First, we welcome Richard Ashworth, who's President and CEO of Tivity Health. That's a leading provider of healthy, life-changing solutions, including Silver Sneakers, Prime Fitness, Whole Health Living, and Wisely Well. Richard joined the company last year after a long career at Walgreens, where he rose actually from being a store clerk to president and helped to transform the company into a global leader in pharmacy and health and wellness. He's an influential voice in public health policy and in the future of healthcare. He holds a Doctor of Pharmacy degree and a master's degree in business administration. Richard, thanks for joining us today. We're also pleased to be joined by Dr. Jon Bloom, who's Chief Executive Officer of Podimetrics. That's a virtual care management company dedicated to preventing diabetic amputations, which of course are one of the most debilitating and costly complications of diabetes. The company was founded in 2011 by Dr. Bloom and engineers from MIT and Harvard, and it now has a growing team of passionate and mission-driven individuals devoted to improving the lives of patients with diabetes everywhere. Dr. Bloom is a board-certified physician and an entrepreneur with more than 20 years of experience in tech development, patient monitoring, biomedical research, and healthcare delivery. He previously was a clinical assistant professor and staff anesthesiologist at the University of Pittsburgh Medical Center. So, Jon, it's terrific to have you with us today as well. And last, we welcome Nick Loporcaro, who's the Chief Executive Officer of Landmark Health. That's a value-based house call provider that serves seniors and chronically ill patients across 18 states. By bringing doctors, advanced practitioners, and care team members into the home, Landmark makes about 400,000 house calls a year, and I'm sure that number is growing. Nick joined Landmark from McKesson, where he most recently was president of McKesson's U.S. Pharma and Specialty Health businesses. And in that role, he oversaw business development, sales, distribution, and operations across all markets. So Nick, thanks for joining us today as well. I've asked all 3 of our panelists to start us off today by taking a few minutes each to introduce themselves and their organizations a bit more and tell us more about the services that they provide for Medicare Advantage plans. So Richard, we're going to start with you. Take it away, please.
Thank you. Thanks, Susan, and hi, everybody. So I'm Richard Ashworth, as Susan said, President and CEO of Tivity Health, and it's great to be here with everyone who's dialed in today. We've got quite a bit of diversity on the group, which is always appreciated. Just real quick, want to thank Mary Beth Donahue and Robin Garacki for their great work at Better Medicare Alliance. This is really helping us to be part of the discussion today, so we're very thankful of that. Susan shared a little bit of my journey. I started as a stock boy in high school working at Walgreens, but that's where I fell in love with pharmacy. And I saw how the pharmacists in that local community were going far beyond just filling prescriptions, but also providing a lot of guidance and support to their customers and to their patients, from life events to things to buy out front to, of course, their medicines. But it was like a whole life discussion. So I decided to go to pharmacy school, did that, stayed at Walgreens for a very long time, and left there most recently as the president before I came here to lead Tivity. And one of the reasons that I came to Tivity Health was actually my experience as being a pharmacist. And that's where I really learned about focusing on improving the lives of adults. And I did that through medicine and through treatment. And now I'm doing that through physical activity, through social engagement, through mental enrichment, and through alternative and complementary medicine. So things that are helping people live healthier lives. Our flagship program is Silver Sneakers. It's a fantastic program, been around for over 30 years. It's been helping Medicare Advantage patients and Med Sup plans both in our mission. And our mission is quite simple. It's just to prevent illness. And we want to help people live their best lives and with age, but with vitality. So I spend the majority of my career focusing on treating illness, on observing the complex factors that lead to chronic disease. But now at Tivity, we get to jump in front of that. And so we get to be more proactive. And I've seen that firsthand in my last year and a half of being here, is that we have a great healthcare system that is symptom-based, but now we can help people live healthier, happier, and longer through a proactive, healthy lifestyle. So 25% of the variation of your human lifespan is determined by the genetic code, meaning 75% is something else. And that's like what you eat, whether you exercise or not, what zip code you live in, who you hang out with. And so in innovators in the aging space, our mission is to just help you make those right choices, make them simple, make them accessible, make them engaging. So we've proven that Silver Sneakers works. And so that's the fantastic part about the program is we did a study with Avalier Health, and they did kind of a comprehensive scientific view of our program, the healthcare costs, the outcomes, and wanted to make sure that our program worked. And so we work really close with our Medicare Advantage plans, and we're making sure we're helping them to meet the goal. So how does it work? It works by reducing the overall healthcare costs by 16%. And that's a very matched study against people who participate in the program and those that don't. And actually, we saw a 26% reduction in hospitalization and medical costs. And so that's the big driver of where the benefit comes from. We also help on star ratings, on quality, which is a big, obviously, conversation today. The way we do that is people really enjoy the program. They love the program. So there's this halo and kind of positive affirmation of the program. So they do better on all the KPIs. So they take their meds more often, specifically in hypertension and cholesterol, which are generally asymptomatic and hard to remember that I need to take my medications. Our members do that more. They have lower rates of readmission. They get higher rates in vaccinations. They do more disease screenings, like pretty much every metric that could be better. Silver Sneakers members do that. So we're pretty proud of that. And we know that makes a difference in the lives of our members. So we know that they're going to live longer, but more importantly, they're going to live higher quality and more connected lives. We've got 18 million eligible members today, but I do want to just introduce one because I like to make sure people can really get a feel for what we're talking about. So I want to introduce you to Margaret Masters. So she's from Louisiana. She is awesome. So she's an exercise enthusiast. She loves group fitness classes. When the pandemic hit, she was one of the first ones to figure out how to go virtual, how to still get her group together and be a part of the Silver Sneakers class. And her in-person classes, they were suspended for quite some time. And so she loves to dance. They call her the dancing queen. She's really involved in her community. Her neighbors, her family members all know her. She's got lots of hobbies. One is watching the New Orleans Saints football, but she's very serious about that. She's also 98 years young, and she won our 2021 Silver Sneakers Member of the Year. When I think about what we really do here, the real promise of Medicare Advantage, it's not just lowering costs and better outcomes, but it's to help our individuals be like Margaret, right? Not only live longer, but live healthier, live happier lives. So I really do look forward to sharing more as we get into today's discussion, but hopefully we can all just be a little bit more like Margaret.
Great. Well, thank you, Richard, for that great profile of all the good that you all do. Let's go now to Jon Bloom and tell us about Podimetrics and the work that you do, again, in an extremely important area of preventing amputations for patients with diabetes.
Thank you. And I also to say how honored I am to be a part of this discussion, especially with an organization with such a critical mission. How do we get best care possible to our Medicare beneficiaries? And for me, I started off as an anesthesiologist, and I just remember I'd spend at times whole days in the operating room doing nothing but amputations for patients with diabetes. And forgive the hyperbolic statement I'm about to make, but I at the time, the way I framed it is like, how can we still be doing Civil War medicine for something that really shouldn't happen anymore? Like if we could just detect them before they're this massive wound that's now infected or gangrenous. Like this seems like it's a lot of morbidity, mortality, and cost that was completely unnecessary. So while at grad school out here in Boston, we came together to try to start a company. Could we do this? My background had been in monitoring systems, and what we came up with was Podimetrics. But before I talk about that, course, diabetes, big problem. What people don't recognize is about a third of the cost of diabetes are linked to complications in the lower extremity. A single amputation can cost as much as $100K, which is very expensive. But most of the cost comes from the hospitalizations, the ER visits, and outpatient visits that this particular patient incurs throughout that year. There are very complex, high rates of heart disease, lung disease, kidney disease, et cetera. It's a very complex patient with diabetes that has been there for quite some time. For us, the key is going to be engagement. What we created was a mat that goes into the patient's home. We just ask them to step on it for 20 seconds a day, and then they can go on with the rest of their life. We're going to try to give them this, through that action, a comfort to know that someone is keeping an eye on them. We collect thermal data from that mat that comes to our servers in a HIPAA-compliant and secure fashion. And then we can run machine learning on top of that to try to identify problems before they happen. So probably a couple of the key studies that came out, it was a 7-center trial that came out in diabetes care. We could detect 97% of the wounds in the bottom of the foot a little over 5 weeks before they clinically presented, about 37 days on average. This is a big jump in time to do something about it. And what we can do there is have a very simple offloading protocol that had been validated in 3 randomized controlled trials prior. We have a nursing team that then partners with the patient to run this quick protocol. The basic idea is we have the patient walk less for a short period of time, and that doesn't work, escalate them to be seen by the clinician. And we run that, we have actually fairly dramatic results. One study was published late last year from Kaiser Permanente. We were able to save about $1,000 savings per member per month. So $12K in that plan year, driven by a couple key metrics. One was a 52% reduction in all-cause hospitalization, so it's across the board, a 40% reduction in all-cause ER visits, and a 26% reduction in all-cause outpatient visits. Further, we reduced amputations by 71%, and fortunately, not a single one of our patients, and these are all very high-risk patients, over half of them had already had an amputation before we picked them up on our service. Not a single patient lost a limb on our watch during that trial. It has been a wonderfully exciting program to be a part of. And right now we partner mostly with Medicare Advantage firms, with government to try to get our systems into homes to get this touch point. So again, we can identify problems before they present so that they don't have to see someone like me in the operating room and have that mortality. If I didn't say it, the 5-year mortality of an amputation is twice that of cancer, 63% for any type of amputation. It's something that we have to stop. It disproportionately affects our minority populations or rural patients. It's something that we have to be committed to partner together on to try to end.
Oh, that's really extraordinary, John. And if I recall correctly, I believe it's the case that 1 out of every 4 Medicare dollars is traced in some way to diabetes. And obviously, you're talking about a big chunk of that spending that you can avert, and not to mention the enormous benefits in terms of quality of life that you're giving the patients you serve. So thank you for all of that. Let's go now to Nick to tell us more about the work that Landmark does, again, in serving MA plans and MA beneficiaries. Nick?
Thanks, Susan. Appreciate being here with this panel. So Landmark Health, as Susan mentioned, I think the elevator pitch is think of us as a mobile geriatrics practice. So probably the best way to think of us is we're an in-home medical care, practice. It's comprehensive longitudinal care. Our patient population is the 8 to 10% of the MA population. Our average patient, and we affectionately refer to our patients as our Joes and Josephines. So our average Josephine is 78 years old, has 8 chronic conditions, is on 12 medications, high frailty, high acuity, limited in their ability to get out. And so what we bring as a interdisciplinary team, Susan alluded to it earlier, we're talking about physicians, nurse practitioners, dietitians, social workers, psych nurses. I know at one point we're going to talk about SDOH, and one of the data points I like to share with everybody, the second provider that joined the company early on is our Chief Behavioral Health Officer. So SDOH has been part of our fabric from the beginning, and understanding, the impact on individuals' health, especially when you think about this population. We were recently acquired by Optum, so I'll speak more from the traditional Landmark lens, but are now part of an effort that we're calling Home and Community Care, where we're bringing together 6 other organizations as we look at opening the aperture on that longitudinal comprehensive care program. And the importance of MA to us is, quite frankly, we wouldn't have been able to build this business had it not been for the partnerships with Medicare Advantage plans. We're a fully at-risk value-based program. So from the perspective of lowering costs, we come up with a baseline on MLR. We have to guarantee reduce costs. And if we don't, we not only not make money, we have to reimburse. So that's one item. The real importance of what we do is the improvement in quality of care that we deliver to these individuals. And I was recently interviewed by a group, and I remember one of the interviewers saying, well, you're a lower cost site of care, right? I said, actually, quite the contrary. We're a very expensive site of care when you think about it from a unit perspective. We're sending doctors into homes anywhere from 6 to 18 times a year, an hour at a time, spending time with their caregivers and their family. Now, that one hospital admission that's avoided, that one emergency room visit, that's where the cost implications are. But think about the quality and improvement in the quality of life we're offering these individuals. Like Richard, I'll share just a personal story of what got me here after spending 16 years at McKesson. And I'm grateful in my 20 years of Medicare, every change I've made has brought me one step closer to the patient. And I think this is the penultimate of that opportunity. And when I had found out about Landmark, I met the founder of the company. I've been with Landmark 3 years. The company was founded. But 8 years ago, when Adam Bowler was telling me the story of Landmark, I literally looked at him verbatim and said, so you send doctors into homes like the old days? What he didn't know at the time was I was in the process of transitioning my mom to an assisted living facility back in Montreal. And what I wouldn't have given to have been able to offer a service like this to my mother, it just took such a hold on me. Now, all kidding aside, I tell people this is kind of like Back to the Future. So we're bringing quality care into the home based on the ability to leverage technology today, based on leveraging programs like MA plans are able to offer us, so that we can go and take risk on these folks and look at them from a longitudinal perspective. Really, in essence, this is population health.
It truly is. And Nick, thanks so much. And again, thanks to Jon and Richard, again, for describing the amazing work that you do for plans and for beneficiaries. So Nick alluded to the next topic that we wanted to tackle, which is the social determinants of health, so-called SDOH. Those upstream drivers of health that, as one of you said, really are the drivers behind most of our health status in life. Most of the things that exist outside the clinic, outside of the healthcare system, outside of the sick care system as we know it, that really do impinge on premature mortality, morbidity, and everything else. So as we think about moving more and more upstream, because understanding the literature of social determinants of health, there are the things that we can do to tackle issues that are close to people's healthcare experience. One of those is just providing transportation to medical appointments. But then there are these really upstream pieces that where so many of you are engaged, as Richard is, preserving health for people as much as possible. And I guess one question I want to ask Richard of you and social determinants is, when you're taking a person who's spent a lot of his or her or their life, inevitably, as most of us have, with a certain set of habits, how successful are you in kind of turning those habits around later in life, getting people to understand that you can always buy yourself extra units of health, if you will, no matter where you are in the life course, in all likelihood, by engaging in these kinds of activities? Tell us a bit about that.
Yeah, it's a great question, Susan. And one of the things I would say is it's each individual at a time. You know, there isn't some presentation you can give and a whole group of people sitting in an auditorium go, that's right, I'm going to start running, exercising, giving back to my community. I haven't done it for 75 years, but I'm going to start now, right? That's not how it works. It's definitely on an individual basis. And one of the benefits of Silver Sneakers is not all the amenities, a really good, robust gym network, a really good virtual engagement platform, a way to connect with others through social connection and, like groups together. So if you like to, cook certain types of food, or you like to travel to certain types of places, you can get connected to other people. Those are all the kind of outputs of it. The input of it is the tribe. It's the community with others. And if you can get, this is true with my children, it's true with us as middle-aged adults, and it's true when we're in our latter part of our lives, is that we're highly influenced by the people we hang out with, who we spend time with. And, you know, COVID has been really rough on this point on social determinants of health, because not only was routine medical care avoided, not only were people more isolated, of course, and we know that the virus had a disproportionate impact on this population, with over 80% of the deaths coming from those that are over the age of 65. It's about getting them connected to a healthier tribe, right? A group of people who care about healthier lifestyles and so forth. And the reason I say it's individual is, you know, I have conversation with members all the time, and, you know, I think about what would motivate me if I'm 75 or 80. What would motivate me? Probably spending more time with my grandkids, or, you know, just wanting to be around longer and spend time, or maybe there's some things in my life I didn't get to do. But I find that every time I have a conversation with a member, it's something slightly different. And so I think the way that you get people is on an individual basis, and then getting them parts of communities. And community is so important. It was Julianne Holstad had this stat where they tracked people who, you know, just simple longevity of life, and you looked at all the determinants of those that lived longer and what was true. And the number one thing that was true is that they were connected to others. That was actually more of a, you know, statistical input than even physical fitness or, you know, eating right, which was quite surprising. So I think it's on an individual basis.
And that makes sense, because as we know from other research, social isolation has roughly the effect on your health as smoking.
Yep.
So addressing that and getting the indirect benefits of the greater activity surely is a path to better health for so many people. Great. Well, Jon, I want to go to you, because you're dealing with the social determinants of health from another perspective, and this will impinge a little bit on another topic we're going to discuss, which is health equity. So many of the people you serve are living out the realities of disadvantaged lives, life in food deserts, for example, life in communities where it is too violent to get out and walk the streets for exercise, et cetera, et cetera. So how do you factor thinking about those upstream drivers that lead people, unfortunately, to the situation that you find them in with diabetes, helpfully served by secondary prevention, which is preventing the amputation, but maybe past the point of primary prevention in many respects. So how do you factor that into the work that you do?
I think it has a major, just not only our company, but we think about other companies trying to help these populations, is that it should be a major driver of design. There's so many companies, of course, that can leverage mobile phones and apps. And, you know, I think in this cohort, you really have to find, they're going to try to solve the needle. It has to work in all those homes. I think there's a study that came out maybe late Q3 of last year that suggested 41% of Medicare beneficiaries lacked access to an internet-connected phone or computer. So we're hoping to use all this, you know, telehealth and visits to get them to all these patients. That's why landmarks, like to get into the home, that's really how you get some of the best care you can. So for us, anything that required a smartphone or even internet at home, you know, those are major points of failure. We had to get it into every home. So for us, it's cellular connected. That was a big piece. You know, there's a number of things. We want to make sure that the patient did not have to pay for the system. That it could be covered by a payer. Again, that's one of the wonderful things about an MA plan when you have those kind of alignment of incentives. And I think that's going to be the key spot. We still have to get better, you know, better education starting very early. Social determinants of health begin to determine health in utero. So really early on to give them that proactive understanding of what these choices can mean for them. And of course, extra social policy. There's a lot of work we have to do to really solve this problem. But once we start to care and take these patients on, we got to make sure that it works for every one of the patients, not for the few that happen to have access to some of these enabling technologies.
Do you ever think about adding a separate set of activities to your company, which is truly in the primary prevention space, using perhaps some of the tools and probably addressing people much earlier in their lives?
Well, certainly for for the patient we care for now, we have a daily touch point with them. They step on our mat, usually about 5.5 to 6.5 days out of the week. So we have this moment, this relationship where we can actually get a deeper assessment of what's going on in their health and then get that information to the people who are driving care to the patients, whether it's a landmark or the care management infrastructure of a health plan, et cetera. So I think that's important. But certainly as we've really gotten to know this patient and really gotten to know the problem of diabetic foot, I think we're going to continue to broaden our ability to care for these patients. Ideally, not just secondary prevention, but primary prevention. And I think if we're going to say we're going to solve this problem completely, it can't just be a look at the most critically high risk. I think we need to have a broader approach to end the problem.
Great. Thank you so much. And Nick, staying on this question of the social determinants of health, you essentially are going right into homes. You're taking care of that issue that I alluded to earlier that so many are trying to tackle, which is getting people transportation to their healthcare appointments. You're obviating the need for that by going directly to people in their homes. You're also seeing what's going on in homes and the individual personal environment in which people are living and the degree to which that impinges on their health. Talk about what Landmark does in that particular domain.
It's interesting, Susan. You know, one of the things I'm immensely proud of from the perspective of our program is our providers obviously going into the home. And I have to share this because it is a real sort of pride point for me. When the pandemic hit and we're all going remote, literally within a month of everybody going remote, our providers were dogging us to get them PPE so they can get back out to see their Joes and Josephines in person. And we were ramped up to 70% face-to-face within the first 60 days and now still at about 80%. And, you know, the importance of that and what we get in the model is when we're in the home in that initial visit and subsequent visits, we're opening up the cupboards, we're going into the fridge, we're looking for falling hazards, and we're looking for those habits. And I'm going to share two quick, I'm going to say anecdotal stories, even though they're true. And it goes to the behavioral components, right? And how behaviors take a long time to change. I always joke with people, I say, you know, I've had 56 years of being me. I get better at being me every day. Well, we need to understand that about the psyche of our patients as well. And Richard alluded to it. One of our Josephines, the nurse shared this story, you know, walks in and Josephine has the oxygen tank and, you know, she's got her 8 comorbidities and we walk in and she's rolling a cigarette. And the first thing she says to our nurse is, don't tell me to stop smoking, right? And that's reality. I mean, those are the things we need to deal with. And so it takes time. It takes that relationship you've got to build with the caregivers, with Josephine to get them there. We had another time I went on a ride along with one of our doctors and we met this gentleman who is what I would call semi-homeless. His son gives him a bed, but he lives in the community center during the day, which is his local church. And, you know, the doc was talking to him about his sodium intake. And the gentleman said something very simple, but very profound. He looked down at him and he said, look, doc, I understand that I should watch my salt intake. He goes, but if there's no other food and I'm hungry, I'm going to eat the fried chicken that's available to me. Right. And that's reality. And that's sometimes what I think we miss. I'm a mechanical engineer by training. So I have at times, you know, I take a dispassionate view of looking at the activities and plugging them all together. And then you've got to step away and think about what's reality here. You mentioned the food deserts, right? You mentioned the access, and recently been interfacing with a company that's food for medicine and embrace what Richard's working on upstream. And I was on a panel recently and I made the shocking statement that we continue to look at the world as post-acute. I'd like for us to be out of the post-acute business one day and not have to get to the acute event. And I know that's a pipe dream, but that focus of how do we get upstream, how do we influence those behaviors, and how do we get people into programs like Richard's and getting into those healthier lifestyles, right? I know we've been talking about prevention for years, but for me, that's what SDOH is, right? It's really how do we solve for those pieces so we can avoid these acute events.
Well, as I mentioned earlier, you can't talk about social determinants of health without going right to the question of equity and health equity. And so much of what all of you have described, frankly, is the consequence of many, many years, generations of lack of equity and health equity across much of our society. I dare say that Josephine, who is still smoking despite using an oxygen tank. The data would suggest, I'm not saying this was the case with her, but the data would suggest she's possibly on the lower socioeconomic end of the spectrum, because that's where we know a lot of the people who are still smoking are. And as we know, given what we have learned over the research that's been done in recent years over the extreme degree of death and disability that has always plagued the Black community, that is increasingly the case also in the low-income white communities, and really gets back to, frankly, the disintegration of the social fabric in many communities. We know this is probably a problem that's going to get worse, if not better. So that said, let's talk about what you all think you can do to address this situation of health inequity. By working, as you certainly are doing so much with lower income Medicare Advantage beneficiaries, but thinking particularly about the kinds of dynamics that we've already described and ways you can be sure that you're ministering to the needs or really addressing the needs of those people who really have been on the disadvantaged end of the spectrum from the standpoint of health equity. So let me go back again to you one more time, Richard, as we think about that. It's one thing to have some relatively healthy Medicare beneficiaries put on their silver sneakers and walk around the mall. What about others on the lower side of the income spectrum?
Yeah, this is it's a great topic. It's one that we're pretty passionate about here. One thing I think, in terms of the social determinants and their positivity on lower socioeconomic groups, the key would be to get more Medicare Advantage enrollees, honestly. So because the MA program is so much more efficient and better at attracting those that are, below the poverty level. In fact, over half of Medicare Advantage patients are below 200% of the federal poverty level. And that's like 39-40% for traditional fee-for-service. So what you see is, a higher proportion of people who have, different needs or different requirements. And we've been doing a lot of research in this front, because trying to make sure, how do we get those members in rural communities and in certain communities that are a little tougher to get to? How do we get them, into healthier behavior? And what we found is that low-income seniors have the highest level of stress and the highest level of anxiety. In fact, 30% of our minority seniors said that they had a significant decline in their physical activity all through COVID. 20% of our rural seniors said they're worried about how much food they have and if they're going to have enough money to actually get the next meal. And because of the capitated model and the way MA works, they're incentivized properly to address social determinants and whatever the health inequities are, based off the geography that they're after, they're seeing. The Chronic Care Act was great because that allowed MA plans to be much more flexible in the way that they offer supplemental benefits. I think that's great. There are three things, though, I think, when it comes to health inequity and social determinants that kind of come together. And I'll start where Nick was, which I think his organization, Landmark, does a great job of this, which is focusing on high quality, cost-effective interventions. So those are evidence-based outcomes. And the way you do that is by knowing the patient really, really well. And you can't do it any better than in their own home. I mean, that's such an awesome model. So I love that. I think that's one. I think the second one is we need the community. So we're always, looking at others to kind of help. And, we're talking about, Civil War, or you go way back, it was communities took care of each other. And so there are many community-based organizations. They're not all equipped to be the best business partners, right? Good mission, good purpose, but maybe not all the infrastructure. We need to help those community-based organizations connect with providers like Landmark or programs like ours, or access to good clinical capability that's simple to use, but gives all kinds of, necessary information to prevent serious complications. That's a big opportunity. And the last one for me is we have to actually define what SDOH is. So just like in pharmacy world, which I know really well, or in the medical world, things are, classified, they're able to be billed against, they're able to be described, they're able to be documented. We need that for SDOH as well.
Great. Well, thanks so much. Well, let me go, let's vary the order just a bit here, and I'll go to Nick first and then come back to you, Jon. Nick, as you think about health equity and the ability, again, of Landmark to make a difference there, you described the scenario that I invoked of a Josephine who's smoking and possibly a lower income senior at that. but how can you fold this awareness of health equity increasingly into the work that Landmark does?
Well, a couple of things. I think one, I applaud the efforts around some of the supplemental benefits programs. I alluded to it earlier, food as medicine. And, when you think about that on the surface, people think it's obvious, but when you think about reaching the right individuals that are in those food deserts and getting them healthy food matched with where they are in their health, depending on their chronic conditions, depending on their ethnicity, right? These are things that matter. So I think the supplemental benefits is now, and I won't get political, is our ability to sort of loosen the purse strings a little bit on the social services side and bring it in to the healthcare side of the world, understanding the impact on health. So I think the more of that we can start adopting, the greater reach we'll have into these communities. Now I'll put back sort of my engineer hat here. And as I think of this, is one of the mantras I have for my team is density is our friend. As we continue to build density and the geographies we're in, we now start to get better momentum. We're getting better reach. We're able to expand in, quite frankly, and I'm going to speak business, into areas that may look less attractive from a business perspective, but we're able to start bringing down our unit costs to then penetrate even deeper. Rural communities, right? Start leveraging telehealth as well. And telehealth, not in the sense of, because we talk about food deserts, there's bandwidth deserts out there as well, right? People don't. But there are technologies that are phenomenal, and how do we continue to leverage that? And it's almost like what I call this flywheel effect. The better we get at it, the more people we have, the more reach we have. So that's sort of the lens we take, Susan, as we look at expanding. And albeit, I know we're talking MA, but even like the duals, and then next step being the Medicaid population. And the more density you can build, and the greater. And I think, if you were to ask Richard from his pharmacy days, you look at those models, there's a lot to learn there from your presence in the community, that reach, that trust that you can build with these communities. I think we'll start to solve for them. I mean, there's a myriad of other things that we need to be thinking about, but those simple steps and that awareness, leveraging the community players Richard mentioned, they may not be the best business partners, but boy, can you leverage the local church, the community center. I mean, there's a lot of influence there on how we can get people to change those behaviors and accept these services. Not everybody's readily willing. We talk about our program and everybody says, wow, that's great. Like, who would refuse it? It takes a lot of effort to engage people, believe it or not, into our programs.
Yes, one hears it over and over again about people who like the theoretical possibility of somebody coming to their homes, but they really don't want people to see inside their homes. You probably run up against that yourselves.
Well, they don't want to admit. Look, I remember going through with my mom, prior to having the transition to assisted living. She was fine, or nerve, right? I'm from an Italian immigrant family. A lot of pride there. Like, I don't need anybody taking care of me. I took care of 4 kids, and so that we tend to lose sight of those things, right? And because we map things down on paper and go, well, this is how it should work, and then the human factor comes into play.
So, Jon, again, we already, in some of your early comments, explored this ground of health inequity. What would you add to what your colleagues have added? Particularly, does the notion of resonating with other social services providers, community-based organizations, does that resonate with you and the work that you do? Or are there other factors that you would pick up on that they've addressed?
I think we're getting right to the heart of it. For any company, you ask, why do we exist? That's one of the primary questions you have to answer. For us, it's to end amputations. We have to go where the problems are. We have to go right to the populations that are most in need. There was actually a couple interesting things that came out recently. The Kaiser Foundation came up with a statement that diabetic amputations are one of the greatest markers of poor quality care, insufficient preventative care. And ProPublica put out a big expose last year. I think it was called like the Black epidemic, that said that if you're a Black American, your likelihood of suffering an amputation is 3 times that of a white American. This is probably one of the greatest markers, or one of the greatest health inequities we have. So it's a critical one that we had to address. And there's a number of things that we have to do that. You have to go where the issues are. When we get work with a health plan, we pull the list of patients that are in need. For example, in our work in the VA, we're specifically targeting rural populations, patients with limited access to care, to make sure we can get the savings that we need, and of course, better outcomes we can. in those populations. You have to design it, to acknowledge that they have tech literacy gaps and then gaps in just available technology. And then, of course, in our case, since we don't, at least today, have that in-home presence to be able to do everything virtually. So no matter where they are in the United States, we can mail them a system, we can do training over the phone, and to begin that monitoring and eliminate any sort of gaps on where they are, their environment. I think those are critical. If we're going to address those inequities, it has to be universal in its ability to get to that home, and then targeted in terms of the care we want to provide.
I want to turn to something that all of you have said in one way or the other, which is why you're working with Medicare Advantage plans. Now, you're not in all cases only working with MA plans. I think Richard said you're also providing services and for Medicare supplemental plans. Others of you have alluded to wanting to bring on more Medicaid patients, et cetera. So it's not that you want to stay solely or are staying solely in the MA space. But as you all have said, there's a particular advantage to working with Medicare Advantage plans, which has everything to do with risk and owning the responsibility for the health of the patient. So let's talk a little bit more about that, Richard. Again, I know, as you said, you're working also with Medicare subplans, but what's the difference to you of working with MA plans?
Yeah, so there's the business side of it, and then there's the kind of health, and care side of it. On the business side of it, it's growing. It's growing faster than the rest of Medicare, which is great. And the satisfaction rates associated with what people get out of Med Advantage is greater than that of fee for service and greater than that of Med Sup. But the most important part of why we love partnering with our Medicare Advantage plans is we are aligned in what we're trying to do. So it is a full patient at risk 360 view. And because of the setup and the way that the Medicare Advantage plans are able to work, they are able to do this conversation we just had, which is they're able to bring these benefits that are farther up, plus still give great physician networks, great hospital systems doing what they do, great specialists providing their care on the sick side and on the care side, but also getting farther up. The other reason for us is we also know that it penetrates deeper into lower socioeconomic and diverse groups. And we like that. We want to help those populations differently and more to the needs that they have. And so that's another big reason. And then lastly for us is it works, so we know that it's lower cost. And so it's a more effective and efficient way of providing healthcare for them. And so, you think about the premiums and the out-of-pocket costs and what's happening on the member side relative to traditional, everything is better, honestly, and so we love the fact that all those incremental benefits are being provided. And we believe that those incremental benefits, coupled with the good care side, is how healthcare is supposed to be delivered. I spent time overseas in different versions of healthcare, and not buying or selling on anyone being right or wrong. But I will tell you that when a physician, similar to what Landmark does, has the full view and has a direct relationship, things are better for the patient. They have access to someone who can really help them, an advocate for them, someone they trust, especially once you get to know them. And so that's the main reason why we partner with Medicare Advantage.
Great. And Jon, again, you mentioned you work with a VA, a different kind of a comprehensive system that is, in essence, taking full risk and full ownership of patients' health, or mostly full ownership, let's put it that way. But why are you very happy about partnering with MA plans?
I think Richard kind of, one of the key pieces of the alignment of, we're all after the same thing. Let's get the best care possible and reduce the costs associated with the care. I remember, as a quick anecdote, I went back to one of the hospitals that I had, and I'll anonymize it, some part of my training, and I needed the leadership there. And I said, guys, I got this great technology. We're going to prevent amputations. We're going to prevent the ER visits, the hospitalizations associated. And of course, they recognized the buy-in, and they smiled and said, well, you realize, we're the part of the health care system that cares for them when they need that care. And you realize that it's the ability then to take risk that can align, with the just the right amount of care to get the best possible outcomes. And ideally, all of healthcare can operate under that same model. That's really the power of what MA has done. And someone else said it on the panel as well, but it bears repeating. The MA space has really created the ability for companies like ours to now exist and operate. Like now we have a partner that is a perfect partner for us that cares for the exact patients that we want to care for. And now if I can save them a lot of money and at the same time give significantly better care, there's a great business we can both have. It's really been an enabling piece. No surprise, we've seen an explosion of companies that can now service the payer over the past 5+ years, certainly longer. And it's been amazing to be a part of. It's just a wonderful charter that hopefully the rest of Medicare will catch up to.
Yes, in effect, as you say, there's now a business model for prevention where there often wasn't before. So really a dramatic change from a sick care system, really riding on the economics of people getting sick and treating them accordingly in the most expensive system in the world, we will point out. Let's go, Nick, to you as you think about this work now, and particularly in the context of Optum and the work with Optum, because it won't just be MA plans going forward. There's going to be direct contracting entities. The world is going to get very confusing looking with so many different organizations taking on risk, and also in the context of treating Medicare beneficiaries. So let's just talk about the MA piece of this. Why MA, and how do you think things will sort themselves out as we go into the world where there will be many other entities taking very large amounts of risk as well?
Yeah. So Susan, you touched upon Optum, and I alluded to it earlier. We're putting together this home and community care platform that I've been asked to lead the effort on. And our goal is to build this proverbial chassis where we can plug in these capabilities, right? And I'm going to touch on 2 points both John and Richard mentioned. John said it, I alluded to it earlier. We would have never been able to build a landmark longitudinal model in the fee-for-service world. Never. Like I know it's a bold statement, just doesn't work. And I go back to what Richard said. If you want a holistic view of the patient and take care of them, you can't do it in a fee-for-service, construct. So as we look at this, today it's longitudinal, it's post-acute, we have at-home, visits, urgent care. Start thinking about that in a broader context at some point and start thinking about home health, hospice, hospital at home. How do you connect all of that so that, again, you can go further upstream, incorporate some of what Richard's organization is doing into sort of the healthy living. And as they get into that journey, you're holding on to them. What I think is incredible for us as partners in MA and for MA plans is think about capturing that life throughout that whole journey. We have no reason to go anywhere else. But one of the things I've got great empathy to our MA partners on is that churn. How do you avoid some of that churn? If you can get people enrolled in these programs, why would they go anywhere else? Especially giving them quality and investing. And I'm gonna, John said this. I think we've seen great evidence from the MA plans in investing back those benefits, right? And truly delivering quality. Yes, there's the cost component, and we don't shy away from saying, we've got to do this profitably in order so we can keep investing. So I think it's the best of both worlds because we really are, doing good in a platform where you can do well, and then you can just have that confidence of continuing to invest with better programs. And hopefully, maybe it's not a pipe dream. We'll see it in my lifetime of really getting upstream so we can start cutting down on these acute events and not have to take, unfortunately get to the point where John's organization is helping with something that's a necessary evil, so to speak, and doing it in a way that we can do it more efficiently and with better care. Ultimately, they'd love to avoid even ever getting there.
So let me slightly alter this question. I've asked you now, all three of you, why you want to work with MA plans and what are the advantages of doing that. And essentially, you've all made the case that the MA gives you the business case to do it is that you do. Let's talk about what you might want or need from MA plans to even further benefit the beneficiaries that you're serving now. What, if anything, would you put on the list? What would be in your on your wish list of things that MA plans maybe could do even a little bit better in terms of addressing the beneficiaries that you're addressing day in and day out? And now I'm really going to flip the order a bit and start with you on that one, Nick.
So I'll have 2 points. One is my wish for MA plans and my wish from MA plans. And my wish for them, and we mentioned it earlier, supplemental benefits, more of those. I hope CMS and Medicare look at how do we offer these plans even more opportunities to leverage programs like that and continue. I know we've said upstream probably ad nauseum here, but how do we provide for that as a component of healthcare? My ask of our MA partners, and as much as I said it before, or I have empathy for them, is figuring out who's delivering the benefit, right? Because at ground level, I can tell you no one's ever going to dispute Richard's model, Jon's model, or mine. And as we elevate and then we get to the actuaries and reconciliation, boy, that's real interesting in the field day. And it's not easy because all of us are going in saying we're going to save 15%, 20%, 30%. I had one of my MA customers say to me early on in my tenure, I don't know that I've saved 150% yet because as you put these all together, it's not happening. So searching for that clarity on who intervenes when, how do we segment the population through their journey, and how do we best help them navigate, not just help the patient navigate, how do we help each other navigate in that space? And I think that's a role right now born on, the MA plans. And it's something I don't know that we're spending enough time on. And, getting all of us together in understanding who should intervene when.
Fascinating problem. Have you seen any models of where this is working well, where plans are able to sort all of these out and assign to players the appropriate set of responsibilities and give them appropriate credit for the work that they're doing?
We've seen it. There's evidence of it. Typically, with a smaller plan and a tighter geography, it's a little easier. So there are some lessons learned, and we float those up in hopes that we can adopt these across the board. And look, the one thing I always share with my teams is there's a lot of room here for a lot of players. I mean, there are a lot of people out there that need what we do, and they're in the many millions, right? So I think adopting programs like this, and I think what we're all tend to be guilty of at times is we're always worried about, competition and who's going to take that share versus, again, I've said for 20 years, I'm naive enough to believe if you keep the patient as the North Star, the rest will follow. And it really does. I think if we can have that discipline of thinking that way, we can truly align all of our services to ultimately give better care, better quality at a lower cost.
Great. Well, thank you. So, Jon Bloom, same question to you. What do you need from Medicare Advantage plans? What would you like from Medicare Advantage plans that would help you do the work you do?
It's an amazing question. I hadn't thought of it until you had asked it. But I think you only manage what you measure. That's such once you can see it, you know how to fix it, and you can see your progress against it. And unfortunately for diabetic foot, there's like 200 codes that make up diabetic foot. Like when we moved to ICD-10 and modern coding, we have great granularity, but what we lost was clarity on the issue. So my request would be for plans to actually assess their diabetic foot expense. Most haven't because of this complexity. They see big numbers in diabetes and not really recognize what's driving it. The only firm I'll share is the one that shared it publicly. The VA had estimated they were spending $3.2 billion in diabetic foot every single year. And every time we go to a national payer and we give them this code set, they're also finding they're spending in the Bs. It's this massive problem that is one of them described as the singular biggest problem that they ever had that they didn't know that they had. And I think that's the critical thing is we think about what drives it. Now that we're getting a better sense of how to measure it, assess that problem. And if there is a challenge, fortunately there are systems out there that can address it. That's probably the biggest one, recognition of the problem.
Well, and anything that has Bs after it is a big issue and well worth their attention. Thank you so much for that. Okay, so Nick, your turn. What do you need? What do you want? What would you like to see from MA plans?
I think you mean Richard, Susan.
Oh, pardon me. I'm sorry. We already did you, Nick. I was giving you a second crack at that question. Not. Okay.
It's fine, Susan. We all want to be like Nick. Yeah, we all want to be like Nick. So it's a good question. I haven't really thought of it like that either. I would say it's maybe two things, and it's a little bit of a lens of what Nick and John hit on. First is, a lot of the benefits that are provided today, there are still some, qualifications required to be able to receive that benefit. So it's not eligible for all, right? And I think the more we can widen the aperture on, especially the SDOH services, to everybody, so that they don't move into a spot where, if we would have been a little farther ahead, we probably could have helped. I think we can always fall in that trap of only focusing on the sick or someone who's qualified. And so there are, indoor air quality, and there's pest control. There's many types of services actually available under Medicare Advantage through the supplemental benefits. And there's big implications on asthma for one of those, and big implications for living conditions. And so I think maybe widening that. And the second one for me is that when we say at risk, thinking about, and this is a good point that Nick made, is there's many great providers out there, and we spend a lot of time thinking about the competition of each other. And the reality, though, is that, and the plan has a central component in managing this. And I've seen this from Anthem and from Humana and a few others who have really taken the time to do this. But what you can do is put all those providers together into not one contract, not to be crazy about it, but like one kind of view about how all the interventions, which have to be coordinated and understood, back to billing codes, back to how we all communicate with each other, back to that central patient, and work our way back. That's still the work to be done. We're not fully interoperable, right? As an entire ecosystem of providers and people who care, just trying to help. I saw this in pharmacy world. When a diabetic patient came in, they would talk about their disease differently than the way the doctor's materials that they took them home with, different than the way I described it, different than the way that their family described it, and so they were very confused about a lot of things of their condition. And again, that's a simple one of literacy and then consistency of nomenclature. But there's many other areas where contractually, or the way that we're incentivized, and the way that the right intervention at the right time by the right partner, I think there's still an opportunity to kind of coordinate that in a stronger manner. And I think that would benefit the patient in the end. But there's so much good about MA that when you ask the question on what else would you want, it's something I'm actually going to reflect on, because I think about, the big difference of MA was things like dental care and vision and hearing, these benefits that are so core to the population. So it's great that we already have those. And then what else could we offer? It's a really, really compelling question.
Great. Well, I want to thank all three of you for a very, very engaging conversation. And we've covered a lot of ground in just this past hour. As you all have said, Medicare Advantage has given you all the business model to do what it is that you do. And you possibly wouldn't even be in business were it not for Medicare Advantage plans, both from the standpoint of supplemental benefits, which now can be offered through the services that many of you are providing, and also just the inherent risk-taking nature of the enterprise and taking risk that it benefits organizations that are reducing costs and avoiding care, as you all are engaged in. We've also talked at length about the social determinants of health that you are addressing in various ways, and the health equity issues that essentially also create the ability for you to do what you do and address those issues of inequity that have resulted in poor health for so many individuals. So I want to thank you again for a terrific conversation, Richard Ashworth, Jon Bloom, and Nick Loporcaro. Thanks again to our audience for joining us for this conversation, and have a great day, everybody.
Thank you.
Thank you.